Those of you who don't know me, my name is Amber. I'm one of the third-year pediatric nephrology fellows. I've had the pleasure of speaking at a few of the ASN wrap-ups or the rounds since I got to present ASN for you all. But I'm excited to talk to you all today about pediatric combined liver kidney transplants. That's been what's been the focus of my fellowship research for the past 3 years or so. And I've really enjoyed working with Jody Smith and many other transplant people across the country too. So while I did talk a little bit about some of the data I'll talk about today, I think it'll be fun to go through more in depth about what CLKT looks like in pediatrics and hopefully show a little bit more of the research I've done since then. All right. I have no potential conflicts of interest in relation to this. I'm hoping that now I'm almost done with third year that maybe I'll start to add some fun disclosures too. So my goals for today. So like I said, my goal is to go over what combined liver kidney transplant looks like in pediatrics right now, including going over common etiologies, surgical processes, immunosuppression, and the current pediatric data that's out there. With that, I would like that to be my background to talk about some of the research I've done. First, looking at CLKT outcomes in the pediatric population as a whole. And then talk a little bit more about what the future of my research is looking like in that as well, and talking about polycystic kidney disease. So just to start to go over this, and I know that everybody knows probably this better than I do, but because these are going to be different acronyms I'm going to use in my presentation, combined liver kidney transplant, or CLKT or CKLT, is when a liver, whole or partial, and kidney allograft come from the same donor and are transplanted together. Sequential liver kidney transplant, or SLKT, I won't talk about as much, but it's when there's an isolated transplant of either the kidney or liver, and then the subsequent organ later. So either it can come from different people or the same donors as well. Kidney transplant, or KT, I'll be mentioning is kidney only transplant, and then liver transplant, or LT, is liver only transplant. So in pediatrics, there is a bunch of common indications that they talk about for combined liver kidney transplant, but if you sift through it, a lot of groups talk about these three main groups or diagnoses as a whole. So the first group is metabolic or immunologic defects in the liver that cause kidney failure. The most common is primary hyperoxaluria type 1, or PH as it's abbreviated sometimes. But this group also includes other things like methylmalonic acidemia, different kinds of liver fibroses, but the things that happen in the liver that cause kidney failure. The second group that we talk about are diseases that cause liver and kidney failure together. And in peds, the most common is autosomal recessive polycystic kidney disease, or ARPKD. But again, there are other things that fall into this group too. And then finally, is secondary renal failure post-liver transplant. So hepatorenal syndrome being a problem, CNI toxicity, et cetera. Today, I wanted to specifically talk a little bit more about PH and AARPKD because as you look into the research, that's more of the things that we talk about and more that's focused on in pediatrics. So for primary hyperoxaluria type 1, it's an autosomal recessive disease, and this is the most common and severe form. What it is it's a defect in the liver-specific peroxismal enzyme alanine glyoxylate aminotransferase. It basically leads to increased oxalate. And so what happens in the kidneys is there's deposition of calcium oxalate crystals, and that leads to renal failure. It can present as kidney stones early on, and then eventually you look at these deposits that go all over the body as well. And so in peds, this is one of the most common CLKT indications in pediatrics and discussions. And then the other piece is autosomal recessive kidney disease. So this is the most common renal cystic or ciliopathy disease in children. It's associated with the PKD-HD1 mutation, causing a defect in fibrocystin, and that's what causes the cyst to grow. So what's interesting in pediatrics is that usually the most common presentation is that there's kidney failure first before you even see, or if you even see any liver issues, but it is possible for the liver to have issues as well. It makes it interesting when looking for our research to try to figure out if we can encompass everyone who has some sort of PKD, because it means looking at other diseases and definitions of diseases that basically focus on the liver too. So there is a possibility of hepatic fibrosis early in life, which is why this also ends up being a discussion of whether these patients need kidney alone, liver alone, or if they need to have a combined transplant as well. So surgical considerations, I am not a surgeon, but from what I have read and what I have deciphered from what people have talked about, combined liver kidney transplants are more complicated than sequential liver kidney, which makes sense, and definitely more complicated than kidney and liver alone. As with every transplant, the goal is to keep this cold ischemia time as short as possible. And it may seem obvious, but if the kid is anuric or the patient's anuric or has some sort of etiology where you foresee needing dialysis, you need to consider CRRT during or after procedure, especially with the primary hyperoxaluria kids, they tend to need dialysis post-transplant for a little while too. A lot of the surgical complications tend to come from the liver, bleeding from the liver, vascular thrombosis in the liver, and GI bleeding. But interestingly, a good chunk of these kids, the delayed graft function of the kidney is more common than having complete non-function of the organ. And within at least pediatrics, there's really no, when talking about immunosuppression during and after, there's not really a universal standard for immunosuppression post CLKT. It's pretty center dependent. In general, it seems to be that whatever they're doing for their kidney immunosuppression is what they're doing for their CLKTs as well. But looking through just on the center studies, it's been pretty variable even within the center itself. So the use of induction for immunosuppression and type of agents gets pretty variable, and even the maintenance post can include a slew of things that we've all used before, including calcineurin inhibitors, anti-proliferative agents, mTOR inhibitors, and steroids. So one of the questions that comes up too is a question about immunoprotection from the liver, and there's lots of suggested mechanisms as to why. However, at least in pediatrics, there's not really a lot of data out yet that talks about whether this is supported. There's one set of papers that came out that looked at UNOS data. UCLA itself talked about their own, and while they've seen decreased acute rejection of the kidney in CLKT versus the KT patients, one of the things that makes it challenging is if you actually look at the raw numbers, the number of combined liver kidney transplants is way less than the kidney transplants as well. So while interesting, there's not a lot of supportive evidence, at least in pediatrics, that tells you if there's truly less rejection or if there's any sort of support. And so one thing I wanted to talk about today was talking about the different outcomes from different studies. And so what I will say is I did a generalized summary of all the studies that I had been able to read about so far. And all of these either included pediatrics or just solely focused on pediatrics. What makes it challenging is that a lot of them are either single center studies that come out and just talk about what their experience has been. There are a lot of groups in Europe, including one database study that I included in the primary hyperoxaluria that are looking at that as well. There's one group that looked at methylmalonic acidemia. And then just to say it, because I didn't include it, there are a lot of studies that come out about AR, PKD, and PKD as well. They're a little more challenging because they're focusing on obviously their whole center outcomes when it comes to kidney, liver, and combined. And so there's not a lot of data that comes out from that as well. But to say it, at least for like the few studies that I've seen, at least a couple center studies that came out just talking generally about their experience with combined liver kidneys in their centers. Their rejection rate for the kidney has been about 30-ish%. One center talked about 20% of graft loss of their combined liver kidney patients, but overall had pretty good patient survival with about 90% at 5 years. For the studies that came out about primary hyperoxaluria, interestingly, while I didn't include the numbers for combined liver kidney transplant, there wasn't really much of a significance in their groups between rejection, graft loss, or patient survival. And then the one study about methylmalonic acidemia, just to be able to compare it to the two, they had like a rejection rate of 50%. But one of the things that's missing from talking about all these studies too is there's a lot of cool things that come out of single centers because they can really go into what their transplants look like, what each patient went through, what all these different things happen with each patient that you may not get when you do database work either. But one of the big studies I didn't want to talk about, at least in pediatrics in the US, was a study that came out from Kalinescu's group in 2014. It's very similar to what I will be talking about for my group as well. What they ended up doing is they used SRTR, and they looked at all the CLKT recipients that were registered within that, and that was 152 at that time. And their database was between 1987 to 2011. And they compared it to liver transplant and kidney transplant alone. And it's all liver transplant and kidney transplant alone of all etiologies. They excluded multivisceral transplants and retransplant. And their outcomes, they looked at graft survival, including time of transplant to graft failure, patient death or last follow-up. And they also looked at patient survival, time to death from transplant or end of study. So I think overall, before I go into a little bit of their data, since it leads into ours, I think the outcomes were really interesting from this. But the problem with this data was that there was not a lot of comparison, honestly, between the liver alone and the kidney alone patients. And so while I think it was useful, they had basically said this is what the pediatric population looks like right now in all these transplants in the US. It's hard to kind of pull a lot of use out of it per se. And so I didn't include everything that they talked about, but some of the things they agreed on was the most common diagnosis is that primary hyperoxaluria, polycystic kidney disease, and congenital hepatic fibrosis were the most common. And if you're interested, they did list out all the different, like what the recipients and donors look like the age differences, what cold ischemia times and everything look like for that specific group. And even talking for about graft loss for liver and kidney respectively, like I'm happy to have the numbers out too, but they basically put the survival probability curves for the liver graft of the combined liver kidney and then the kidney graft of the combined liver kidney. So while it's really interesting, it's a little hard to pull out like what clinical data we can get from this if we're not comparing it to something else. But one thing that I thought was really interesting was that they put their survival curves up comparing the kidney alone, liver alone, and the CLKT group. And it looks like the CLKT group, the survival curve matches more of what the liver alone group looks like, almost to a T, compared to what the kidney alone group looks like, who seem to have better survival probability. And so which there's a lot of different, I'm sure, stipulations that can come from this, whether it's etiology, how sick they are, we have dialysis in kidney, et cetera. So but I think it's very interesting to find that the combined liver group tends to follow the survival of the liver alone patients. And so with that, this paper, this was released in 2014. And so this was like almost crazy to think about this, but like a decade ago at this point. And so when we were reviewing this and we were talking about this as a group to look at what outcomes come now, I think some of the things we thought we could add and what would be different was whether or not we could find good comparators of kidney and liver to combined liver kidney. Obviously, there have been more kids that have been transplanted since then, so we'll have a bigger population as well, and try to answer some other questions coming out of this data. So with that, the reason why I wanted to talk about this paper is it bleeds very nicely into the research that I've been doing with everybody else in our group. And so the next goal for me today is to talk about my research in combined liver kidney outcomes in the pediatric population. So why do we care? Why was this important to us to talk about? So multi-organ transplant, as you see, is pretty uncommon actually in pediatrics, but it's still something that we talk about and it's important that could be life-saving and life-improving for children. Guidelines and consensus statements don't really exist because we don't have a lot of data. And in general, a lot of data doesn't really exist either. There's not a lot of management when it comes to pediatrics specifically. And so that's why I worked with Jody Smith and other transplant docs to talk about combined liver kidney transplant in children. So our method, it's a retrospective cohort study of pediatric CLKT. And in this number, we actually had 284 kids total, so that was a lot more. And then we used liver and kidney transplant alone. These kids were transplanted between 2001 to 2019, and we used OPTN, the network, to look for these. The study population was any kids less than 18 years of age at time of listing. So we recognize that we're using a lot of etiologies when we're comparing all these groups, and we keep that in mind when we look at our outcomes too. Our outcomes that we wanted to study was comparison of recipient and donor characteristics for the groups, kidney graft survival, liver graft survival, and then looking at patient survival, comparing the combined liver kidney groups to the kidney alone, and then also to the liver alone group as well. And so I've shown the raw data before, and I'm happy I have the tables. I'm happy to go through some of it again, but I think it'd be more useful to paint a picture of what based on the data, what it kind of seems these patients look like. And so when we were looking at the recipients of combined liver kidney transplants, their ages seem to be a little bit more similar to the kidney transplants, a little bit older than the liver transplant kids. The most common diagnoses were polycystic kidney disease, or some version of the liver version, and primary hyperoxaluria, and then some version of the oxalate nephropathy on the kidney side. They had a higher rate of prior kidney transplants, higher Melden-Pelt scores. Interestingly, more public insurance, more were listed at multiple centers, and more had shorter wait times as well. So looking at these kids, when we were thinking about this, it felt like these combined liver kidneys, the ones who needed it, seemed to be a little bit of sicker kids. They obviously would like to get these organs, they need to be listed at other centers and luckily because they needed it, had shorter wait list times too. The public insurance part is interesting, and I think it's something that we'll need to delve into more, but I don't think we have a lot of data to point as to why that would be. So with that, looking at the donor organs, looking at the transplant, so the the transplant itself, they tend to be higher KDPI kidneys, higher ABDR mismatches. Their organ characteristics overall, there were more whole livers, more end block kidneys, longer cold ischemia times for the liver, but not for the kidney, which is interesting, and more delayed kidney graft function too. And so again, looking at this, we've like talked about this before, but at least when I think easily with the organ characteristics, we'll take what we can fit, right? So like it makes sense that you're going to have more end block, more whole if you're trying to just take a picture of like what you can have for this kid. The higher ABDR mismatch will be interesting to talk about later. But again, the higher KDPI kidney is a little bit of a mixed bag because it could be that we're just accepting what we need for these kids if they're sicker, but it also could be that since we're needing to take multiple organs and fit them into a child, pediatric, the younger age tend to have higher KDPIs just based on how it's calculated out. So it's kind of unclear one way or the other. We did actually look into that and did see that there was a bit of a younger drift towards who was getting, like who were part of the donors, which fits a little bit better with it as well. And so looking at just the plain graft survival between the groups, so this is liver alone compared to, or yeah, liver alone to CKLT and then kidney alone. And just looking at the graft survival undeath-centered, you can see that on the left, the combined kidney, liver kidney patients tend to have a little bit of better liver graft survival overall, right from the start compared to liver. And then interestingly, that the combined liver kidneys tend to do a little bit worse at the beginning, and then after a few years, in general, their slope is a lot less. So after a few years, though, they seem to do better overall than the kidney alone patients. Which I think leads to interesting if you look at the death censored kidney survival, that at the very beginning, if you death censor it, that there seems to be better. It seems to match the kidney alone until you get to about like 2 years out, and that's like gentler slope shows a better survival of the kidney versus a kidney alone, which again, it kind of shows, I wonder if whether or not this has to do with some immunoprotection that comes from the liver as well. And then finally, looking at patient survival, comparing combined liver kidney to liver and the kidney, it's interesting because it looks pretty similar to what the Kalinowski group got for like 10 years ago too, that this group tends to follow the liver alone transplant survival versus the kidney. And I think there's some complexities that come to that, including what the etiology is and how complicated the procedure is. And I'm sure that there's a lot that bleeds into why it would be comparable to the liver alone versus kidney. And so, I mean, our conclusions, like I talked about, there's difference in demographics between the groups. There's the CLKT recipients have higher long-term allograft survival rates at the end of 2 years. The CLKT patient survival was similar to LLT, but inferior to KT. But our group is very recognizable that even though this data is interesting and it adds to some of the outcome data out there, it's really difficult to actually apply this clinically. We've taken a whole bunch of etiologies and pushed them together and used these to compare each other to each group. And so the next steps that we were trying to figure out is like, how can we use this so that we can continue to further and actually give that guidance that we're wanting to and the outcomes that we want to for guidance in combined liver kidney transplant. And so the last piece I wanted to talk a little bit is about a little bit of new data that we're talking about, which is looking at combined liver kidney transplant in pediatric polycystic kidney disease. And so our objectives for that is we're looking at the population of PKD. And that makes this complicated because with the database we're using, it's hard to separate between AD PKD and AR PKD, and we're fully aware of that, but we're going to look at the polycystic kidney disease transplants in patients and look again at the similar characteristics, donors and of the recipients as well, and to compare graft and patient survival between the groups as well. So our methods are pretty similar. Really, the difference at this point is that we are going to look at the kids with a diagnosis of polycystic kidney disease. And like I talked about earlier, while it's not as common, we are trying to also grab those kids who have the liver presentations, and these are the different diseases we look at as Caroli's disease, congenital hepatic fibrosis, or polycystic liver disease as well. And again, we're looking at comparing the recipient and donor characteristics for the three, looking at the death censored kidney graft survival, and then looking at patient survival as well. And so this data is a little bit fresher, but just to go over it. So we have, out of all the patients, so we had 684 transplants that met criteria, 112 that were listed for CLKT and 89 that received grafts. And so looking again, similarly how we did before, looking at the combined liver kidney patients, they were more likely to have a history of prior transplant listing at multiple centers. And interesting, these ones had a higher rate of death on the wait list despite a shorter wait list time. So overall seeming so far kind of similar to the last group we talked about, although we didn't talk about the death on the wait list either for them. And then post-transplant characteristics, most commonly kidney transplant was the most common single organ transplant and transplant overall, which makes sense for how the disease presents. But there was a similar incidence of preemptive transplant to KT compared to CLKT as well. These patients actually had more similar Melden-Pelt scores at transplant to the liver transplants. And again, the donors had higher KDPI, higher DR mismatch, and then they had longer kidney gold ischemia times for these ones as well. So it's interesting. I think it paints a little bit different of a picture that these kids may not be as sick, which make a little more sense. But it's something I think we're going to have to look more into this raw data to figure out and see if there's more we can pull out of it as well. And then we have a little bit of induction stuff. So like thymoglobulin was more commonly used for CLKT. And then we had actually some rejection incidents, which was interesting that CLKT had lower rejection incidents than KT alone when it came to the kidney, but similar to the liver, which again points to whether or not there's immunoprotection from the liver. And while the KT and LT allograft survival were higher among the combined liver kidney transplants, there was not a difference in patient survival at 10 years. And so again, it's like this is listing what we talked about already. But it seems like the PKD patients do have a little bit of a difference when comparing this to that whole group that we were talking about, though they make up almost half of that group as well. And it's interesting because I think that'll be more interesting discussion to have between clinician and patients where you're talking about having liver and kidney allograft survival rates that are different, but that the overall patient survival rate is the same. So the data is limited. I think it's what we have, but I think this will be a more interesting discussion to have when looking clinically at these patients about whether there's better guidance within a certain pathology. And so with all that, why does this all matter? Why do we care? Why is this important to us? And so pediatric transplant just continue to get more complicated. These candidates continue to have these discussions of whether we need multi-organ transplants. And it's been at our center too, that we've had pretty complex combined liver kidney patients as well. With that, there's a high need to continue to report things, not only to make guidelines and to try to kind of guide other physicians as well, but that there is policy that comes with also figuring out how we allocate these organs too. And so that is what I wanted to talk about today. It's everything. That's why I helped with Jody Smith, and I really have appreciated her help and everyone in this research about combined liver, kidney, and pediatrics. So I wanted to thank everybody for listening, and especially thank my group over at Seattle Children's and Jody and Jordan for helping out with this presentation.
Thank you so much, Amber. That was a wonderful overview. And thank you for joining us all the way from the pediatric realm. Really appreciate you taking the time to discuss that with us. Well, we do have just a few minutes here for questions or comments if anyone has any questions or thoughts. Yeah, go ahead, Yuhar.
Amber, thank you so much for the really nice talk. I was wondering, did you guys compare infection rates between the ones who have combined versus the one who have single transplants?
That's a great question. I'll have to double check back on our big table we have, but I don't think we had anything for infection rates. And I'm not sure if it's in the database, but I'm happy to go back to the group and see it because I think that's important. Looking at a lot of the papers, that's a decent, that's one of the significant morbidities that come out of this too.
I think the reason I'm asking is because we tend to see, like what you said, there tends to be more so-called protection of the liver, and they don't get a lot of rejection. So then the question is, do they really need that much immunosuppression, and if their infection rates are higher?
Oh, that's a really good question. I'll look back and see if we can get some of that data.
Thank you.
Any other questions or thoughts? You may have mentioned it, Amber, but tell me again, what's the number of combined liver and kidney transplants that you guys have been doing on average at Seattle Children's?
That's a really good question. I should have asked Jody before I came on here. I will say in my past 3 years, I think we've done one so far. So it's pretty rare. And that one is a pretty complicated one that we've done. I don't know. I think there's a couple other on the call, so I don't know if either of them knows about how many we've done, but it's been pretty rare that we've done them at Seattle Children's.
Okay. All right. Any other questions? Well, thank you again, Amber. Really excellent, and continue the wonderful work that you're doing. Hope to hear further updates as you continue.